I guess I'm going to talk and you're going to drive, correct?
Let's do it.
All right. These slides that we're going to go through tonight are posted in the course, and this one I made absolutely no changes to. We're walking through this for a couple of different reasons. One is to revisit SBIRT, which is Screening, Brief Intervention, and Referral Treatment, which is very effective for alcohol use disorders. And we're going to look at its use in managing pain and prescription of opioid abuse. So keeping in mind that what we're looking at is not necessarily treating people for their pain, because I don't know that you're going to get involved with that unless you're working in a special clinic, but the fact that many of the patients that you see who have mental illness may also have chronic pain and may or may not be on prescription opioids. So as part of the team of treating this patient, it's helpful to understand the process, why they may be on opiates or why they may be being tapered off of opiates, and to kind of help to substantiate the fact that opiates for long-term chronic pain use can be helpful in some people, and in other people it doesn't work at all. So being able to understand that will help you to better communicate with your patients. So next slide, please. This slide presentation and several others that you have had options of reviewing came out of work that I was a participant in, which is CCAD, which looked at helping APRNs, which is an abbreviation that's used in other states beside Alabama, to increase the education that they had related to substance use disorders. So these slides are part of that work. And next slide, please. So looking at opiates, this presentation was created in 2014, and this problem has not gone away. If anything, it's increased in its magnitude and proportions, but to also be aware of the fact that women in particular are particularly hard hit, having more and more frequent chronic pain than men, and they may be receiving higher doses of opioids or more frequent use of opioids as a method of kind of managing complaints. The prevalence of prescription opioid use in those who require substance use treatment is the highest in people who are 30 years old or younger. So if you're dealing with an older person, it is conceivable that they have an opiate use disorder, but they also may have poorly managed pain. And part of this discussion tonight is to kind of look at the differences between poorly managed pain and pain that is not really the issue as much as the fact that they've got an opiate use disorder. Next slide, please. So when looking at the pyramid, considering that addictions only involves a small portion of individuals who may be using opioids, and the 4 C's of addiction for review is craving, compulsion to use, continued use despite the consequences, and loss of control. So as a thumbnail, when you're looking at whether or not someone seems to have a substance use disorder, thinking about, do they have loss of control, do they have cravings, do they have compulsive use, and do they have continued use despite negative outcomes. In this pyramid, we see that there's prescription drug misuse, in which people get prescriptions and they may overtake the medication, sometimes to manage unacceptable stressors or feelings that they may have. And then aberrant medication taking behaviors, which is folks who kind of up their medication without permission, or that they may also have multiple risk factors for developing an opiate use disorder but have been receiving prescriptions anyway. And then there are folks who've got low risk patients with little concerning behavior. And this lecture tonight is to kind of be able to know what the risk factors are for developing an opiate use disorder. So when you're dealing with folks, that you can be monitoring their use as well as their behavior. Next slide, please. So those with low risk patients with no concerning behavior, your initial risk assessment identifies the patient as being low risk. They don't have any factors that would uh, bring you any concern. A lot of times it is about family history, it's about their previous use of substances, their previous use of alcohol, for example, or other times that they have had prescriptions for opioids that they didn't have any issues with them at all. There's no request for early refills. They haven't escalated the dose. And they keep regular schedule appointments. They show up when they say they are. They call and cancel if it was appropriate and reschedule. And because for many pain management places, they request the patient bring in the medication container, and they may or may not. And this is something to consider when you're dealing with individuals who you don't really know whether they're taking their medicine, is just that they need to bring the container in with them so that you can do a pill count if necessary. And the medication counts are always correct. And if you do a urine drug screen on this particular individual, they have the right drug in the urine drug screen and the wrong drug is absent. Next slide, please. Individuals who have aberrant medication taking behaviors increase the spectrum of severity. And this may be some of these behaviors, I would go as far as intolerable behaviors, including forging prescriptions, selling opioid prescriptions, theirs, buying drugs from illicit sources, that they may have had multiple lost or stolen opioid prescriptions. And this may also go with individuals who are on benzodiazepines. They may also have the same behavior. They're not adherents to monitoring requests. So if you ask them to bring in their pills so that you can count them, they forget. They may skip out when it comes to urine drug tests, or give a urine sample that really is water, which doesn't, which demonstrates the fact that they may be avoiding being tested. They have a deterioration in function and at home as well as at work, and they may be resistant to changing the therapy despite adverse effects. They may deny that they're over-sedated. If they are lisping or somehow or another slurring their speech, they may deny that that's happening and may question your ability to determine that their behavior is at all unusual. They frequently may turn the table and say that you've got a problem, not them. And they may also run out of medications early, that the medicine that's supposed to last for 30 days doesn't last but maybe 20 days, and they call in needing refills quite frequently. For some people, only the brand names work, and that's accurate for some individuals. But with an opioid, if the individual is very particular about which one they get, this may also raise some concern. They may not be adherent to other recommended therapies, such as increasing physical activity or behavioral therapy. Then they may say, oh, I can't do that, or I don't have the money for it, or I just won't do that. So they don't have the willingness to try anything else beside that. So next slide, please. So those who actually have prescription drug abuse, is what they're calling it here, is that they have a recurrent problem related to the prescription use. They have the failure to fulfill major role obligations at work, school, or at home. And if you notice that this is information that is right out of the DSM-5, this criteria helps to substantiate the fact that they've got a substance use disorder. They used in physically hazardous situations, and this might be that they use and then drive, or they may be involved in needle sharing if it escalates to that particular point. They may have substance-related legal problems. So if they are have been jailed for their substance use, if they have had DUIs or driving under the influence, this may also flag the individual for further monitoring and or perhaps being extremely judicious if you decide that this is something that the opioid is something that you want them to try with them, and that they continue to use despite persistent or recurrent substance-related social or interpersonal problems. So arguments with spouse, physical fights, denial that they've got a problem at all, and continuing to use. So essentially, the prescription drug abuse level 3 risk factors are in fact substantiating the underlying substance use disorder. Next slide, please. And level 4, what they're calling in this series addiction, is meeting all the criteria for a substance use disorder, which would include loss of control, which involves that when they start using that they can't stop, or they may use more than they intended to. Compulsive use, which is they have to use no matter what they say to themselves, that in order to feel better that they have to use, or in order to feel normal they have to use. And this has become compulsive by this point in time, that it is not necessarily a choice, but they must use. And continued use despite harm. The harm is open to discussion. What the harm is could be physical harm, that they may have elevated liver function tests. It may be that they have harm by exposing themselves to hepatitis C and HIV through needle sharing. And the craving part is that when they're not using, that they crave the substance and must seek it out. With the addiction piece, as they're calling it, the 4 C's of addiction, it doesn't necessarily mean that they also have to have physical dependence, because as we've talked about before with opioids, you can take an opiate for a couple of weeks and end up with a physical dependence. If you stop using it, you will go into withdrawal. That does not necessarily equate to an addiction. So withdrawal does not equate to addiction. Physical dependence is not addiction. So we've kind of walked through concerning medication taking behavior when you're looking at individuals who are getting prescription medications. So next slide, please. So with the SBIRT approach, we're looking at screening, which is an initial assessment. Here you're looking at an individual who's got chronic pain, and before they're prescribed an opiate, to assess for the risk factors and to obtain baseline measures using a PEG scale. I'm unfamiliar what the 6 A's are, which is problematic of using somebody else's slide deck, but a PEG scale is included in the module, which is a 3-question scale using 0 to 10 about an individual's ability to function in their daily life. How much does their pain interfere with, kind of questions. And there are only 3 of them, so it's real easy and fast to use. And that can be used as a marker for whether or not the individual improves with the use of opioids, because part of the reason that you would use opioids in the first place is that you would be able to manage their pain so they could return to or continue to function as appropriate in society, and work, hold a job, and keep house and take care of their children. So part of this screening might be that you're going to say to the person that you're going to implement universal precautions for opiate use, which is an agreement about the rules around the fact that you're going to prescribe for them. And this could also be used for benzodiazepines should you work in a practice where you've decided that the individual is going to have a contract with you in order to get a benzodiazepine, that they must sign an agreement, and the agreement usually stipulates that they can have random urine drug screens, or every time they come in they get a urine drug screen, that you will be doing pill counts, and you'll have prescription monitoring programs that you will be able to check with the state agency that looks at all of the prescriptions that that person is pulling. If you've never looked at a prescription monitoring program, in Alabama, they have a peculiar clause to it that you have to have access to this through your collaborating physician unless you have a DEA number, and then you can have access to it yourself. Many physicians authorize their nurses to have access to this prescription monitoring program, and this allows you to look to see what other prescriptions the patient's been getting, how often they're getting them filled, and who else is writing them. So it can be eye-opening, including if you think that the patient's getting medication someplace else, the prescription monitoring program will tell you, in fact, if they are, who they're getting it from, what amount they're getting, and what the frequency is on it. So it's really helpful to know whether you're the only person they're getting stuff from or you're one of many. So you're going to monitor for the benefits and the concerning behavior. And with a brief intervention, you're looking for saying to the patient, I'm really concerned about how you're using this medication, and that because of that, we're going to increase the monitoring because I'm concerned that you're not using this in the way that I have in mind. And that to tell the person at that point that it is a possibility that they'll be tapered and discontinued from the medication if there's no benefit or if the behavior continues. So getting an opioid is not a lifelong thing, and it is not without strings attached, for a lack of a better way of looking at it, that because some people do not have a benefit from use of opioids, or the opioids in fact increase their level of pain, that it's not something that everyone is going to benefit from. So the person needs to know that up front. And then if you suspect that they've got an underlying substance use disorder, to refer them for detox or to perhaps be put on buprenorphine or methadone, which are two medications for treatment for their opiate use disorder. Now, buprenorphine and methadone also can be used for chronic pain, but in this particular case, it would be because they have an opiate use disorder and the monitoring would come from another area rather than you do it yourself. Because of the CARE Act, buprenorphine is something for opiate use that a person with that special DEA number can prescribe for individuals who have an opiate use disorder. So it is conceivable, if you're working with a physician or if you're working in a practice in which they need you to prescribe buprenorphine, you may end up prescribing buprenorphine. Several classes ago, there was a nurse practitioner who graduated and ended up working for a clinic that focus was on treating opiate use disorder in rural area in Alabama. So her entire job was around assessing and treating individuals with opiate use disorder. So it is possible that that might be something that you might choose to do or be asked to do when you leave here, when you graduate. So knowing these pieces is helpful to know, for the fact that it may become a piece of what treatment options that you have for people. Next slide, please. The methadone, however, because for anyone who has an opiate use disorder, must come from a methadone treatment clinic, you will not more than likely be prescribing the methadone. So after your initial assessment and you've assessed using the PEG score or the 6 A's, which I'm unfamiliar with, and you implement these other particular pieces, you're going to monitor for benefits and concerning behavior, as well as compliance with the agreement. And the agreement may be that they come in on a monthly basis for a reassessment and evaluation and get another prescription, because the prescriptions will only be given if they arrive for their appointment. Next slide, please. So again, with the initial assessment, you're going to check the state prescription monitoring program and scan available records. And if you don't have access to this information, they recommend that you delay making any decisions about that. If you are in practice and patients come in to see you because they want to get put on various medications or treated for various medications, it is prudent, if you don't have enough information, to reschedule the patient in a short turnaround, like maybe 1 week or 2 weeks, to continue the assessment if you don't have enough information. That it is reasonable to say, I'm just getting a feeling for who you are as a human being, and I understand that you're having some trouble, but I really feel that before we go any farther, I need to get a little more information about you. Many times people get stuck in the, I've got to write a prescription for this person before they leave the office, when in fact, sometimes it's best that you be prudent before you write a prescription, to get the information that you need to better understand what the issue is. Because if you can't identify a target, it's really difficult to treat them. So having people come back will also give you an idea about whether they're going to be reliable and continue to work with you. Otherwise, you write a prescription for somebody and they go out the door with refills on it, and you may never see them again, or see them 6 months to a year later. And your name is on that prescription bottle. And so consequently, it's always prudent to make sure that you have all the information, or enough information to make a decision before you move forward. Next slide, please. So, risk factors for all types of addiction, which are good predictors of problematic prescription of opioid use. So the concept is if an individual has problems with addiction, that there's a high possibility they may have problems with prescription opioids, which would include past cocaine use, a history of alcohol or cannabis use, a lifetime history of alcohol or substance use. So if they're in recovery and they used to have a problem with alcohol, it still counts as a tick for the fact that they have had a history of substance use. The family history, of course, and a history of legal problems, which may or may not have put them in touch with other individuals who may use substances as a method of coping. Tobacco dependence is considered a risk factor, and a history of severe depression or anxiety. Next slide, please. So that's the section 1 on this, which we just walked through SBIRT real briefly. And I want to walk through section 2, which goes a little more in depth on this particular topic, looking again at opiate use, the consequences in today's society for opiate use, and a little more in terms of what your role might be in managing individuals with chronic pain. Okay, this is the second one. So next slide. Actually, 2 slides. Thank you. So the SBIRT approach to managing pain and prescription opioid abuse, and I would encourage you to consider that this also applies for any other controlled substances, that you're looking to maximize the benefits and minimize the risk to the individual. So this is about implementing a monitoring framework which helps to, number one, ensure that the individual understands that there is a structure to your practice, that there is a structure to how they're going to get the prescription, as well as certain requirements that they're going to be asked to conform to in order to get this particular treatment. Now, the patient may or may not agree to all of these particular pieces, but this is part of the process, that either they agree to continue with the particular framework that you set up, or if they choose not to, which is their right, they can go on down the street. So next slide, please. So why would anybody want to use a monitoring framework? Partly this is about, there's increased evidence that a structured care program can assist patients in reducing or resolving concerning behavior. So this is not unlike knowing that your nursing license, yes, Deborah, it's in the module. I put it in there a little while ago when I was reviewing what I wanted to cover tonight, so it is in under the PowerPoints. So if you consider with your nursing license in which having any trouble with the law, having any substance use, including cannabis use, might lose you your nursing license. As attractive as smoking marijuana may appear, the risk of losing your nursing license might be too high of a consequence to even go there. So those kind of things in place keep people from doing things that they might otherwise do if there weren't consequences related to their behavior at all. So next slide, please. So in a study, an outcome of structured care, this study looked at 171 patients concerning behaviors receiving structured opioid care. 45% adhered to the agreement and resolved concerning behaviors. So with the structured opioid treatment setting, they kind of got in line, and in order to get the opioids and to receive the treatment that they wanted and felt that was important to them, they adhered to the treatment and resolved the concerning behaviors. 38% left and didn't come back, so they self-discharged. 13%, which is about a little higher than the average number that you would anticipate, were referred for addiction treatment. So those folks, despite the fact that they had entered into this contracted agreement, their behaviors continued to escalate. And because of the 4 C's, the loss of control, the cravings, the compulsions, and the continued use despite negative consequences, they couldn't manage in this kind of a program. And so it helped to highlight the fact they had become they had developed a substance use disorder, and so they were referred for addiction treatment. So 4% had consistently negative urine drug screens were weaned from the opioids. Now, consistently negative urine drug screens was probably about the fact that maybe they weren't using the medication. It is conceivable that people, when they get a prescription, don't ever get it filled, or if they get it filled, they never take it. So if you get a urine drug screen and the patient doesn't have any medication in it, you have to wonder, is there any point in continuing with this? So 4% were weaned off of the opioids because of the fact that they didn't appear to be taking them. So next slide, please. Following these individuals over a 6-month period of time, looking at standard of care, looking at the structured care with urine drug screens every month, compliance checklist, and motivational counseling, and then low-risk patients getting standard care, which is pretty much business as usual. This just generally shows the fact that the high-risk patients who were receiving the structured care didn't have as many aberrant drug screens as those who were high risk receiving standard care. So this speaks to the fact that the monitoring, in fact, gives the provider a better handle on whether or not an individual has lost control with their substance use, particularly if they're high risk. So you would say, well, if they're high risk, why did they put them on an opiate at all? Sometimes the risk-benefit analysis works out that the risk is worth taking, particularly if they're able to resume the functions of daily living, because many people with their chronic pain are couch-bound or bed-bound or chair-bound, and that having their pain managed returns them to a higher level of function, which is really what the goal is. So next slide, please. So when you're going to look at implementing a monitoring framework to explore non-opioid treatment, which should be first and foremost, when you're dealing with individuals who come in to see you for a depressive episode, or they come in to see you for anxiety and they have underlying chronic pain, part of your treatment of their anxiety may be also to look at the amount of pain that they have and what they can do, what's within their control to help manage their pain so they can have a better functional quality of life. This is about a holistic treatment, and it would include perhaps encouraging people to exercise more frequently, which also can help their depression, to seek various forms of exercise that they can tolerate, that they can do, to have a realistic discussion with them about the benefits and risks of opioids. And in this day and age, because I think that the public has been so well educated about how scary and evil opioids are, there are some folks who are quite frankly afraid to take them that could benefit from them. But if this individual was needing an opioid, that they encourage this to be considered as a test or a trial about how well the individual might respond to the opioid. So it's the opioid that's the test, not that the patient is the test. So it's about the medicine. Is it going to work for you? Is it going to be beneficial? Defining treatment goals is consistent with any time that you're working with a patient. What is it that they anticipate that they're going to get out of this treatment? What are their goals? Are their goals to return to being able to exercise with their family member, to go for walks that was something that they used to really enjoy but can't do anymore because of the degree of pain? So knowing what the patient's treatment goals are can kind of help you also to measure whether or not they've had a level of improvement with the medicine. And to encourage patient responsibility, that much like any other individuals who has chronic issues, that the patient has the responsibility of helping themselves get well, which you as the provider are being a coach and a cheerleader to get that person to commit to, well, you're supporting them in their own commission to the fact that they're going to do a behavior and do it on a consistent and reliable way. So part of this process is also explaining what it is that's going to happen and what the safety issues are that you're going to be monitoring for. Next slide, please. So continuing to explore non-opioid treatments, it could be non-opioid drugs such as the use of gabapentins, NSAIDs, other medications that may support joint comfort. Sometimes it may be about exercise with flexibility training such as yoga, physical therapy, and complementary therapies, which include yoga, meditation, and guided imagery. Both of these pieces here, with the physical therapy and the complementary therapy, can improve the individual's feeling that they have more control over themselves, over their body, over their lives. And as people generally don't respond well to being told the pain is in your head and that we want you to do these other things so that you can learn to distract yourself, while that is accurate, it is sometimes helpful to consider how you'd feel if an individual told you that. It is helpful to encourage a person to realize that by doing these other things, they themselves are activating the positive neurotransmitters in their brain, which can help them feel better overall. Cognitive behavioral therapy may be appropriate in terms of what self-talk that they've got going on. And in terms of the injections or pumps, those are really outside of our scope for this particular conversation. But injections for pain management usually are done by other individuals, and they may be referred to pain clinics for those. So next slide, please. So what are the benefits and the risks of an opioid? The potential benefit is that they get pain relief that they return to a quality of life that they may have used to have had, that they get functionality back. And those are important things for the individual. The negative aspects or the potential risks include functional impairment because they're over medicated or over sedated, physical dependence, the potential for abuse and addiction, the potential for overdose, which, if managed, can be negated so that it doesn't happen. But what you don't have any control over is what other medications or substances that the individual puts in their body that you may never know. And the other potential risk is an increased pain sensitivity, which opioids can increase the individual's pain level. Next slide, please. So side effects and benefits: sedation, constipation, impaired driving, physical dependence and addiction, and emphasizing the fact that physical dependence, becoming physically dependent, and when they stop the medication or run out of the medication, go into withdrawal, is not the same as an addiction. I don't know that people can hear that often enough, that physical dependence is not addiction. And the risk of drug interactions. And you all are pretty well familiar that a benzodiazepine and a opioid has a potentiating factor, so that 2 and 2 don't make 4, they may make 6. And sometimes there is the risk of unintentional or intentional misuse, depending on the individual. Again, the potential for abuse, addiction, and death for all individuals with chronic pain patients are between 3 and 19%, depending upon whose stats that you're looking at. Next slide, please. So, serious opioid-related consequences. This is pretty much all over the news at this point, that there are, and I think this figure is a little on the high side, 980,000 opioid addicts in 2010, and the number of emergency room visits in 2008 were 305,000 visits, which is a very expensive proposition. And opiate-related fatalities in 2007 were 14,000, and essentially 450 deaths in 2007. Next slide, please. An update to that is that most recent studies from 2016, in which the death toll has been totaled at this point, that the number of synthetic opioids has increased with overdose deaths. And this picture here is something I found today on the internet, that the amount of fentanyl for a lethal overdose is shown in the vial on the right, and the amount of heroin on the left. So just to give you an idea about what small amount of fentanyl is needed for an overdose. Next slide. Overdose and deaths. Next slide, please. Current death toll for overdose deaths is up 21% from 2015 to 63,000 individuals who have died in 2016 from unintentional drug overdose deaths. At this time, they are beginning to tease out the unintentional drug overdose deaths, because they're not all opioids. Some are other substances. Some may be alcohol related, because they're all categorized as drug overdose deaths. But 30% involve synthetic opioids, including fentanyl, and the fatality from synthetic opioids surpassed prescription opioids as the leading cause of drug overdose deaths. So while changes in prescribing patterns has decreased the number of opioids out there on the market, the number of deaths from synthetic opioids has increased, so that they now involve 30% with the use of synthetic opioids, which is a pretty considerable number. And a large number of the individuals who died in 2016 died because of fentanyl and its extremely strong strength. So next slide, please. So at this point, what we don't know is exactly how to tell whether somebody is going to run into problems with opioids, because individuals who develop opioid use disorder have to have exposure to the opioid. They have to have ongoing and continual exposure to it, which is part of the reason why there have been recommendations recently to limit the number of prescription days in which an individual has for their first prescription. Prior to this time, prescriptions for opioids were written very liberally, that you might get a 30-day supply when you sprain your ankle with Lortab. And that they have found that the longer the exposure to opioids for a prolonged period of time increases the risk of developing an opioid use disorder for those who didn't have a sensitivity to it in the first place. So the best tactic for helping people to avoid an opioid use disorder is to never have exposure to opioids in the first place. So those who have chronic pain can benefit from chronic opioid use, but who is not going to benefit is pretty much still a crapshoot, because we don't have a test that will determine which individuals will benefit and which individuals won't. So in this one, they talk about offering an opioid prescription as a test of the medication. I don't know whether this medication is going to work for you, so let's give it a try and see whether or not this medication, testing the medicine to see if it's helpful for you. It's a different kind of a flip than we're going to test you to see if you can take this medicine or not, but it's a test to see whether the medication would be beneficial. Next slide, please. Part of the problem that we're having at this point is that the evidence for chronic use of opioids just isn't there. As you know, randomized controlled trials, which is the RCT, are normally of short duration, being of less than 4 months. They're very expensive to run, and it requires a lot of work in order to get a control group and another group that you can compare the responses to. And most of the sample sizes are very small. So if you remember your experiences looking at the EVP class, that randomized controlled trials are what you're looking for. You're maybe also looking for a synthesis of the evidence that will give you a much more robust feeling of to know whether or not the evidence is there to say whether this helps or not. So the control trials aren't there. The sample sizes are too small. They're also biased by the fact that pharmaceutical companies sponsor them often. The pain relief may be modest, or they may have no functional improvement. And to remember that all chronic pain is not opioid responsive, because as we discussed last week, the way in which pain receptors travel are different with chronic pain than they are with acute pain. So next slide, please. And there's a variability in the response to opioids, partially because human beings, despite the fact that they look similar, are not the same, and that their polymorphisms, which are about genetic changes in the human body, may vary enough that people don't respond to the same medication in the same way, and that not all pain responds to the same opioid in the same way, and that some people have an incomplete cross tolerance between opioids, so where one medication may work, other medications may not work at all. If you have ever had opioids yourself, if you think about one worked and the other ones didn't, So you were aware of the fact that some medications, even though they're very similar, have no efficiency. They may cause more side effects than benefits. So next slide, please. And this particular piece goes along with some of the information we talked about last time, is that long-term opioid use can actually increase pain sensitivity, so that people who believe if I take an opioid, it should help me, when in fact the opioids may be increasing the pain, which goes along with why it may be helpful to taper the patient down and get them off the pain medication altogether, because the constant um, changes in levels of medication may be part of what the problem is, and that they have an opioid-induced hyperalgesia. So um, understanding these pieces can kind of help you support why people may be tapered off their medicine, so that as the patient comes in and is flabbergasted that their pain doctor's taking them off medicine, that you'll be able to at least provide some support um, to them. Adam said here that there was 65,000 in 2017. I don't have that figure. The one that I have is from the CDC, that was also in, I believe it was U.S. World News Report. So the figures are not important in terms of the number of people who died from opioid overdoses. The tragedy is that it's still going on despite the education, despite the fact that more and more people who are using opioids for chronic pain may have an antidote that they could take if their family member overdoses. But with folks who misuse opioids, oftentimes they do this alone, and there's no one around to resuscitate them with the naltrexone. So some of those also impair and increase the likelihood that someone's going to die from an opioid-related death, secondary to the fact that often people use or misuse opioids alone. Next slide, please. So the withdrawal-mediated pain, if one were to draw it out, the upper level of this line is where people are comfortable, and the wavy part about this is the various drug levels. And this, if you could also consider that benzodiazepines, particularly Xanax, has the same outcome, and instead of pain, consider anxiety, that when the level drops, they may experience increased anxiety secondary to withdrawal, which translates with opiate withdrawal, increase in pain. Deep bone pain frequently happens. So this withdrawal mediated pain, it helps to support why the individual needs to keep taking the medicine, even though it's illogical. But those folks who have opioid addiction issues or opioid dependence issues, in this particular case, they may be using opioids despite the fact that they've got ongoing pain. To support them coming off of this really requires a lot of work on the provider's part to coach them to trust that coming off of this medication is much better than staying on it. So next slide, please. So this particular model here is looking at morphine equivalence, with the concept that a certain level of morphine equivalence, the higher the morphine equivalence, the higher the risk for opioid overdose deaths are, mostly because of the level of drug in the person's system and the receptor being saturated, that they have that risk. So concept-wise, more providers are looking at the morphine level equivalents and trying to bring the patient closer to the level recommended. What has happened recently is the CDC came out and revised the guideline that they released in March of 2016, because with the morphine related equivalents, it didn't take into consideration that when patients are taking buprenorphine or methadone for their opioid use disorder, that those morphine equivalents must be higher in order to ensure total saturation, so that they cannot receive any benefit should they take another opioid. So consequently, they've had to revise that, saying that that was true except when individuals are on medication-assisted treatment and are in recovery using buprenorphine or methadone. So just to kind of be aware that the morphine equivalent doses increase. The higher the morphine equivalent doses are, the higher the potential is for that individual of having an overdose. And that's essentially what this is about, that there is a standard that they have considered, and that the higher the morphine equivalent dose is, the increased risk the individual has. So next slide, please. I think click one more time. There you go. They're saying here to exploit anticonvulsive synergism. And in essence, what this is saying is that with people who have chronic pain, if they have a placebo, looking at the slide on the left-hand side, that placebo will bring down pain levels. Gabapentin brings down the pain levels slightly better than the placebo does, and morphine brings down the pain level. But when gabapentin and morphine are combined, they have a synergistic effect in which the individual gets better pain control. And that is, in essence, what is being said here. You'll see some information that has recently come out about the fact that gabapentin has got an increased risk for abuse, and that some states are moving to make gabapentin a controlled substance. I don't necessarily support that. I think that this is an equation that people don't quite understand. How come gabapentin has got an increased use, and that individuals who have an underlying addictive disorder are going to use whatever they can find to, number one, up the strength of whatever it is that they're using, but also because the gabapentin may help with some of the withdrawal symptoms, particularly if they have co-occurring use disorders. So for individuals with chronic pain, the combination and using a synergistic effect with the anticonvulsant may also occur. So that's what this is about, that morphine and gabapentin, when they're used in combination, have an improved pain relationship. So when you're working with people who have chronic pain and may also have underlying psychiatric illness such as major depressive disorder, I've seen that more frequently than not, that people come in with a major depressive disorder with chronic pain, working with the patient to identify specific, measurable, realistic, functional goals, because sometimes the pain may not improve, but their functionality improves, and it's important to know, where does this person want to go? How can I do the best I can to get them to that goal? But you have to have specific, measurable, realistic, functional goals, which might include the fact that they're able to get out and drive the car, which, if they're not driving at this point, is returning them to some level of freedom. The goals are created jointly. They're not your goals to tell the patient, but your to coach the patient to understand what it is that they want to have happen and how will they know when they're well. For some people who have become so dependent on family members that they are able to resume some activities of daily living that they surrendered to other family members. And the other piece to this is that it is conceivable and important to say it is possible that the best we can do is to help you be more comfortable, but the pain may not go away because of the degree of damage that you may have, particularly if individuals have failed backs or damaged body parts. That's not going to change, but how they manage and how functional they are in their life, part of your role is to support and to get them as functional as possible. So in essence, I think there might be one or more slides here. If you would click again, Simone. This is an important point to encourage patient responsibilities. And the legal responsibilities are if they have a prescription, they need to safeguard that, to have a lockbox and how to dispose the medication if they're not using it, to not share their medicine with other people, even though they may feel like, gee, I've got some pain medicine, I see you're hurting, let me get you one. To let them know that that is against the law and they should avoid doing that. Keeping their medicine locked up and safe and out of sight, not out on the table or in the pharmacy or in their medicine cabinet, to warn them that sometimes people come in to use the bathroom, and part of the process is that people often scope out what's in the medicine cabinet. Oftentimes people lose their medication because of the fact that someone came in to use the bathroom and walked out with their pills. And to look out for other signs of harm, whether they're safe to drive or operate heavy machinery. And by heavy machinery, I would include a car, a lawnmower, to help them to avoid any, this is preventative medicine we're looking at now, that they be able to recognize when they're having trouble. And what it would look like if they're losing control of their medicine. So saying if you use more than the number of pills that are prescribed every day, and today you take 4, and tomorrow you take 4, and the next day you decide to take 5, and you're only authorized to take 3, that would be a signal that you're losing control of your medicine, so that they know up front that this is a possibility that you're going to be looking for. Next slide, please. Because people may feel that you're looking at them under a magnifying glass and that being part of this monitoring program may make them feel like they're being criminalized for something that they didn't even do. To focus on the fact that this is about patient safety and that the program or whatever structure you set up is to help them to help them to remain safe taking their medication. And the statin LFT monitoring analogy is that by having this monitoring program, it's not unlike when people have their blood level checked for the amount of cholesterol that they have in their system, that this is a process of essentially prevention and early warning. And that this should be a standard policy that if you implement it on one person, you really need to implement it on all patients, so that this isn't one person is set aside as a potential problematic patient and the other patients aren't. You really are not going to be able to tell who's going to run into problems and who isn't, so having this across the board will be probably your best bet for having a safe environment. And this monitoring system would work well for anybody who's also on benzodiazepines, should you work in a practice that prescribes them. Next slide, please. So universal precautions when it comes to substance use disorders, whether it be opiate use disorder or benzodiazepine use disorders, prescription monitoring programs, which most states have at this point in time. It was also supported to continue through CARA 2.0 because the government helps to support the prescription monitoring programs, to have agreements in place with the patient about lost medication, about prescriptions that get lost, about pills ending up in the toilet, whether you're going to replace them or not, and it's recommended that you do not. Urine drug screening, whether it's going to be random or routine. Pill counts, which may be that the person knows that they are expected to bring their medication in with them every time, so that you can take a look to how they're doing with their medicine. And and also having phone follow-up just to double check to see how people are doing with their medicines. Next slide, please. This is just about the contract and the agreement about what your clinic policy is. Some clinics have posted, and I've seen pictures of these, that their clinic is a no benzodiazepine clinic. We do not prescribe benzodiazepines, and they may have a sign in the waiting room that lets the patient know, even before they get back to see you, that they will not be prescribed benzodiazepines. And many other clinics may choose to also not prescribe an opiate for pain relief. So knowing that up front may help save the trouble of folks who are coming to see you just because they want Xanax. I've lost a number of patients throughout time who come in on an initial visit and say the only thing that's ever helped them is Xanax. And when I informed them that they would not be receiving a benzodiazepine, they became irate, and nothing else was going to work beside that. And so some of this is a matter of deciding in your head when people ask you, because they will, how you're going to handle it, which needs to be polite and firm. Broken record works really nicely, which when it comes to assertiveness, broken record is you keep repeating the same thing. You don't change what you say. You don't change how you say it. Broken record is, no, I don't prescribe benzodiazepines. And when they ask you for it again, you say, no, I don't prescribe benzodiazepines, in a nice level voice, so that they understand that this is a wall that you have, and that's not to be breached, despite the fact they may whine and carry on or have a temper tantrum in your office. Some people can be quite threatening, so it's helpful to have a safety plan that you can escape out the door should you need to. Next slide, please. This is kind of self-explanatory, and it recommends helpful strategies should somebody have a positive urine drug screen, which would include, if I sent your urine out right now, what do you suppose would be in it? With the idea that you are kind of setting up the potential for this is what you're going to do, so let's talk about what I'm going to find. Or if you do come back with a positive urine drug screen, say in a matter of fact way, your urine drug screen was positive, can you tell me about how that possibly is? Because it's important to know that urine drug screens are not foolproof, that there are some medications that will end up showing up positive in the urine drug screen, that if you've got someone who you suspect but they deny the fact that they've got anything in their system, you'll need to send it out for further additional testing before you consider that whatever information you got in that test was accurate. There is a high probability that it is inaccurate. So in other words, don't get too excited about it. If it comes up positive, you may have to send out for additional screening. Next slide, please. Pill count, simply said, confirms medication adherence, whether or not the people are actually taking the pills. It minimizes diversion, because if the patient knows that you're going to count the pills, they won't be giving them away. They won't be selling them, because you're not going to give them another prescription if their pill count is off. And it's also important to know what the pills look like, because otherwise the patient may substitute something else, figuring that you really don't know what they look like anyway. So what difference does it make? Adam made a comment. Let's see what his comment was. It's in the files. I posted to our group Facebook an article on comprehensive urine drug screenings. Thank you, Adam. So comprehensive urine drug screenings may be what you choose to do. The issue is, if you get a urine drug screen, have in mind what you plan on doing about it, because a urine drug screen, just to get a urine drug screen, if you're not planning on doing anything with it or making any changes in the patient's plan of care, then what is the purpose of getting a urine drug screen? So know why you're getting a urine drug screen before you just get one. Next slide, please. We're not going to do that because we don't have that film. And discussion questions. What kind of medication agreement, if any, is currently being used in your practice setting? And this is so open discussion, so if you have anything and you want to add, this is a good time. If you've got a microphone, it would be really good to use at this point. Does anybody have medication agreements that they're using in their practice?
This is Karen. I haven't seen one yet.
Okay. Some folks may use them, but it also depends on the practice and their level of concern about patients misusing their medication. I would say, knowing that there are such a thing out there, medication agreements for controlled substances, it's not bad to explore. It is something to consider, particularly if you're going to be working in an independent practice state, that could be protective to you, because a medication agreement will spell out refills, when refills can be called in, what the patient can expect about what you're going to do. So in essence, it kind of sets up the rules for practice. And it can be very helpful. Who's speaking?
I'll say it's Karen again. I said I can see where it's very helpful and it's needed, you know, like you said, especially in an independent state.
So it's something to consider, particularly when you're dealing with a population that may be at high risk for substance use disorders, to kind of be aware of the criteria for when do they cross the line and enter into that substance use disorder area, and whether it's mild, moderate, or severe. And you'll notice that people can choose to proceed with a test for a couple of months to see whether they're going to do all right with the medicine or not. But a test means this isn't going to last forever, and we may decide after 3 months that you're not doing well on this. So it's not a forever kind of a thing. So are there any other questions in regard to what we kind of covered tonight, which was looking at managing individuals with opiate use disorder, looking at individuals who are on opioids for chronic pain, and kind of being aware that even though you may not be prescribing for people who have chronic pain, the opioid itself, it is helpful to know what the expectations are of that individual, so you could be supportive of it, as well as being aware that if someone's on an opioid, that you would probably want to avoid a benzodiazepine, or if they are still having a lot of pain, may consider adding a gabapentin, which can help with anxiety for some people, as well as maybe help the pain overall. So it's kind of a fine line to determine what helps individuals, because some things help some people and sometimes nothing helps. But when you're dealing with individuals who come to see you for depression, the very fact that you're interested and listen and are considering what you can do to be helpful to them, it can go a long way in establishing a relationship with a patient. So that's kind of the end of this evening, looking at chronic pain and the interweaving underlying substance use disorders, as well as looking at managing depression and anxiety in conjunction with chronic pain. Are there any questions before we end for the night? Thank you, Karen. Simone, is there anything we need to talk about?
I don't think so. Not that I can think of. Just
Okay.
any questions anybody has, please post it in the discussion or send us emails. And we'll see y'all next time.
Yeah, and I think that there's a module in there about medication-assisted treatment that's a SAMHSA product. It's kind of a nice, tight summary that is easy to print out. It's only like 16 pages. So that could be a good guideline for looking at buprenorphine and methadone for medication-assisted treatment. So good night, everybody.
All right, y'all have a good night.